Good evening, everyone. This I'm going to present about a case of left main bifurcation intervention in a person with a high syntax score. As we all know, LMCA disease comprises around 5 to 6% of all our angios, and in three-fourths of the time, they are associated with significant triple visit disease. And significant proportion of acute myocardial infarction patients also come with this significant LMCA disease. Isolated LMCA disease is very rare, but is seen in around 1% of the population, more often in females, in which case we have to suspect non-atherosclerotic causes like iodoarteritis. And this case is about a 75 years gentleman who's a hypothyroid, hypertensive, asthmatic, and had a past history of stroke. Not remote past, recent past history of stroke, but however, no residual deficit. More importantly, he's a CKD patient with creatinine of 1.8. Presented with a recent ACS with ECG showing poor RV progression in V1 to V3, echocardiogram showing moderate left ventricular dysfunction corresponding to the LAD territory wall motion abnormality was noted. Angiogram was done outside, which showed this was the angiogram picture, which is showing a significant distal LMCA disease extending into ostium of LAD and LCX, and more noticeably, we can notice here that left system is dominant. So with this picture, he was seen outside, and the LMCA shaft and distal had an 80% disease, LAD 90% proximal mid 7K. Importantly, it was calcified, diagonal had 80% osteo disease, circumflex dominant had osteoproximal 90%. The syntax score was 39, and he was advised bypass surgery outside. But in view of this MRI and MRA of the brain, which was done as part of preoperative workup, which showed diffuse narrowing of bilateral internal carotid arteries, both in the intracranial and extracranial portion, surgeon had refused for a CABG in view of the very high risk, and he was kept on optimal medication. However, continued to have recurrent wrist angina episodes despite of optimal medications. This is when he consulted our hospital, and we had discussed the overall pros and cons of CABG versus a PCI, and the option of PCI, which would also be high risk in view of his high syntax score, left dominant system, moderate LV dysfunction, pre-existing CKD, and past history of stroke. All these kept in mind, and the option of high risk CABG with an IABP support, and definitely with imaging guidance and need for root ablation was kept as a backup. And after discussing with the family, we proceeded. And as we all know, this is a brief slide which I will not touch upon. Most of us are aware. LMCA bifurcation, if the side branch is significant and we want to plan a two-stent strategy, DK crush as of now is the preferred strategy, wherein imaging is strongly recommended. And this patient, we planned a femoral root, 7 French sheath. Left side we put, but coincidentally, the same day on the morning of the procedure, patient had a syncope, collapsed, and he was immediately brought to the cath lab. TPI was inserted through the right femoral vein and IABP through the left femoral vein. And the procedure which was planned had to be preponed by a few hours. And right femoral artery was chosen for the percutaneous intervention, and we used a 7 French extra backup guide. Both LAD and circumflex were wired with workhorse wires. They were pre-dilated, and after pre-dilatation, initial pre-dilatation of both the entire LAD, we did a OCT run. We did an IVUS run, and IVUS showed, more importantly, very decreased high plaque burden, fibrocalcific plaque. There was patchy calcification, and areas were significantly very low, so with this information from the IVUS, which showed patchy calcification less than 180 degrees and not significantly. So we went with a cutting balloon. Flexotome 2.5, 10, and 310 dilatations were done in the LAD, and only 2.5 into 10 was done in the circumflex. Subsequently, the mid LAD was stented initially with a 3 into 28 stent, and later the dedicated LM to LAD proximal and LCX was planned as a DK crush technique, and circumflex was stented with a 3 into 32 stent, and the first crush was done. This is the figure showing first crush, and then first kiss was done, and subsequently LM to proximal LAD stent overlapping with the previously placed mid LAD stent was done, And later, this was the picture after the three stents were placed. But after this, we did pot and a final kissing balloon inflation, and this was our final result and angiographic result. This was confirmed with an IVUS run post procedure, which showed adequately expanded and adequately achieved areas of around 7 in the LAD, around 6 in the circumflex, and LMCA of around 8.5 with good apposition, no malapposition, and stent expansion was appropriate, and which corresponded to our final angiographic result. So with this, and the procedure was intra procedure, we didn't have any on table any adverse events. Post procedure period was also uneventful. Creatinine transiently rose to 2.1, which was conservatively managed, and subsequently it stabilized to around 1.8. Overall, around 100 ml contrast were used. IABP and TPI both were removed next morning. Take home message from my case is unprotected left main interventions can sometimes be challenging and carry a high risk, particularly in left dominant system, wherein around 80% of the left ventricular myocardium is in jeopardy. However, with proper bed preparation and imaging plays a key role. Unprotected left main PCA can be safely done even in higher syntax patients. However, we need an appropriate hardware and a proper heart team approach and appropriate communication with the patient family regarding the risks and the outcomes is vital, particularly whenever we are beginning this complex and high risk intervention program. That center, we should have a heart team approach, and proper communication with the patient family is very important. And value of imaging, how much ever said, is still less only, particularly in left main cases. It is very, very important to ensure an immediate technical success as well as an optimal long term outcome. Very useful to have hemodynamic support devices, IABP or Impella. However, in our center, we use only IABP, and it's important to use. And maintaining a close follow up and ensuring drug compliance is the key to have a good result. Thank you. It is all a good result is a success of teamwork. He went to the collapsed. So immediately IABP TP, a few hours.
And you said you could withdraw the IABP sort of reasonably quickly later on.
Yes, sir. Yes, sir. After 24 hours, immediately after opening the vessel, only the NORAD in the ICU, which was started high dose and shifted to lab. End of procedure, only 2.5 miles was there. Next day, we weaned IABP and removed.
Okay. Any comments, Dr. Pramod, Dr. Jabir? Quick comments.
I think it's a very well done case in a tough situation. A left dominant system, LM bifurcation, crashed on mechanical cardiac support, taken up the patient and went for a complex procedure. She did a DK crush, which is one of the toughest or the most time-taking two-stent bifurcation strategies. But the patient gave time. He was stable throughout with the support. That was a good thing. And the other thing is the syntax score, what I heard was 29, isn't it, Dr. Deepti? You said it was
35.
Yes, sir. And the distal vessels were very good. Though it was a bifurcation lesion, the calcium was not that a problematic calcium. It was not very dense calcium. The arc was not more than 180 degrees. The length was not more than 3 millimeters. So it is a relatively, a balloon strategy was sufficient. And you went ahead with the cutting balloon. Very, very well done case. There is nothing to comment upon. The most important thing is in the left main bifurcation is a precise PCA, and you could do a precise PCA with the imaging support. Only one thing I would like to know from the panelists also, when the patient arrests or in a crash, should we go for DK crush? Should we go for a quick and a simpler procedure? Some patients may not give time like this. So what we would like to know from the panelists. You did a wonderful job, no doubt about it. And in the long run, this gives a better long-term results also as per the data available right now. Now, I am just asking it broadly. If the patient crashes.
Yeah, Dr. Jabir, I think your question is very valid. And I think imaging and also doing a DK crash in a setting where the patient crashed really takes time. And I have to appreciate Deepti for doing it expediently. And choosing IVUS over OCT is also good because the patient's creatinine was high. But I think doing DK crush, the other alternative would have been to do a culotte, because that would be easiest to do in a quick setting, rather than doing a DK crush, which takes a lot of time, and also it was a calcified lesion needing cutting balloon and all those equipments. I think overall it is a well done case. And was the patient intubated, or he was not?
He was intubated. He was intubated.
That also added to your comfort.
Yes. But we could extubate immediately after procedure, few hours only. His creat was high, and 90-100 never was like 60-70. Reasonable hemodynamics, and like sir already told, he gave us some time, though he crashed.
Otherwise, we all prefer to put a stent from the left main to LAD and secure the LAD flow, then think about the circumflex. But here the problem is it's a huge dominant circumflex supplying a large area. Nagul sir, what do you think? Suppose you face such a thing and the patient crashes with a left circumflex dominant.
Yeah, first of all, you have to get the team going, because it's always a teamwork. But I think the simpler strategy could have been do the circumflex first, maintain that, and then do the culotte thing and finish that. But anyway, whatever works, I think Dr. Deepti's team was lucky also, besides being very well done job. So all the best, and let's move on to the next case.
Thank you, Deepti.
Thank you.
Yes,
Thank you.
Great work.
Thank you all the speakers, panelists.
Patil will be